Yeah, good morning, everybody. Has been very exciting meeting. My name is Yosef Zakaria from the Hawk Islands at the University of Iowa. So it's my pleasure to welcome you to the session 10, Molecular and Diagnostics. We have 3 exciting talks ahead of us. I would like to introduce our good friend Brian Schock from UCLA to talk about girentuximab in kidney cancer.
Thanks, Yusef. Okay, so I'm going to give a little whirlwind tour about where we are and kind of where we're going. Just discuss some unmet needs, some of the current imaging modalities, the current role of PET-CT, and really the future and the revolution of immuno-PET-CT in kidney cancer. Well, we have obviously a lot of unmet needs with our imaging studies, so we really have done poorly at distinguishing lesions that are benign versus malignant. About 25% of the tumors that are removed are ultimately benign for small renal masses. We need to do better. We also have a lot of patients who are interested in active surveillance, but as we're applying this to younger populations, a lot of patients want to know what's going to happen in 5, 10, 15 years. I want treatment up front when I'm healthy rather than when it grows 5, 10 years. It doesn't matter if you're 85 maybe, but if you're 65 on active surveillance, people want to know. We need to do better with imaging. And then recurrence of RCC is really a failure of our current imaging modalities. About 40 to 50% of our high-risk patients recur, and it may alter management discussions of adjuvant therapy if we're able to identify disease early. Maybe we're under-treating people with monotherapy. We should be more aggressive, and maybe we're over-treating some patients. So in terms of where we are, well, FDG has been the mainstay of PET imaging. FDG is a glucose analog. It gets trapped in the cell. It's a surrogate of glucose activity. However, in the kidney, it's pretty crappy because there's uptake and excretion, and it's called a blind spot. And there's a paper here, they actually called it a blind spot in the kidney. And some benign lesions, like some oncocytomas, can take up FDG. But there are a couple papers showing the sensitivity and specificity. It's okay. If it's hot, it's more likely to be a kidney cancer versus a benign lesion. But outside the kidney, maybe it's a little better. Well, our current FDG modalities, there's been lots of studies. You don't have to worry about renal uptake. And the meta-analysis shows that the specificity and sensitivity are 95%, both in about a recent meta-analysis of 1,300 patients. So, if you try to order a PET-CT, a lot of times it will get denied because it's not in any of the clinical guidelines. Another thing which people have access to with the explosion of PSMA imaging is, we have PSMA PET-CT for prostate cancer. Well, PSMA is actually expressed in proximal renal tubule cells. There's a nice paper from Sloan Kettering where they look at PSMA. It's actually expressed in neovasculature in the majority of, renal tumors with high expression in clear cell kidney cancer, about 80%. So a lot of people have proposed using this for imaging the kidney. However, because it's expressed in the proximal tubule, it's also very highly bright, and there's excretion, so it makes it really poor for primary renal tumor imaging. And there are about 15 series looking at PSMA PET-CT for detection of metastatic disease, maybe some value there. But look at our guidelines. NCCN, AUA, EUA, they all have language about PET-CT, and basically they say it's garbage, don't use it. There is data, and it is in small series, but until we have well-designed nuclear medicine studies that are performed, these studies will remain investigational, and all you guys will have to do prior authorizations for hours and hours and hours trying to get it approved, unless they're maybe in the Medicare population, which sometimes you can get it approved. Now, immuno-PET is something which has revolutionized prostate cancer. It's revolutionized how we evaluate neuroendocrine tumors with dotatate imaging. And basically, there's some tracer properties. You can use things like small molecules or antibodies, full length or partial. And these are target specific. These should be inert. These are stable tracers, and they should be non-immunogenic. And then they can be attached to a payload, which could be a radioligand for imaging, which would hopefully be have rapid biodistribution, low background. It's easy to manufacture with low cost. You want the half-life to be not too long, but not too short. Now, CA9, this has been a long journey, basically with the discovery and the mapping of the VHL and HIF pathway due to many people in the community. CA9 is upregulated due to VHL loss with HIF upregulation or hypoxia. Great work from Ari Beldegren, Alan Pantuck, and others at UCLA have showed that there's very high expression in clear cell kidney cancer. In a majority of these are diffuse membranous expression. So it deserves, it's a great biomarker for clear cell kidney cancer or hypoxia. Now, there's been a long history of targeting as for maybe imaging. A lot of these are girentuximab based. There is I-124. There is, also now 89 zirconium girentuximab, but also a couple small molecules. One of them from Baris Turkbey at the NCI, and a new kid on the block, this NY-104, to a company in China to image CA9. So it's been a long journey since the discovery of the antibody and the antigen, with identifying how it gets upregulated with hypoxia. There is a phase 3 study looking at I-124, an adjuvant study. Wilex, a company, went out of business, and Telex licensed it, and now it's moving back in favor. So a really long 20, 30-year journey to get this kind of move forward for imaging or potentially therapeutic aspects. People are familiar with the REDEX study. Dr. Digby, Dr. Russo, and Uzo, they led this kind of study about now 10, 12 years ago, where they looked at I-124 in a surgical study, 3 primary endpoints. This was a hard trial to be positive because they needed high levels of sensitivity, specificity, and they needed all readers to have a very narrow confidence interval. And if all those were negative, it was going to be a negative study. They had a lot of non-clear cell tumors, so eventually they increased the sample size to 226. And despite the excellent performance with very high accuracy and positive predictive value, it failed to meet all primary endpoints because of the large confidence interval, and this led to the trial not getting, the agent not getting FDA approved. And with the negative ARISER study, which was the adjuvant trial, this company Wilex went out of business. But other people took it forward. This is work from Peter Mulders, another disciple of Dr. Beldegren from UCLA. He's in the Netherlands. He ended up doing this study with 89 zirconium PET-CT with girentuximab. They had one group of small renal masses and another group potential metastatic disease. All the clear cell tumors were positive. And then in metastatic setting, they were able to show that patients with recurrent disease that were maybe scheduled for surgery, 3 patients had their surgery canceled because they had more disease than expected. So it really holds promise, and it showed that it was really useful. Telex took this and ran with it and did a large pivotal phase 3 trial, which is basically an image and resect trial. Patients who got imaged, who were scheduled for surgery, they had a 7 centimeter or less renal mass. These were patients that had suspicion for clear cell kidney cancer. So a lot of patients who might be thought to be papillary, oncocytoma, or AMLs probably wouldn't be on this study. The co-primary endpoint, sensitivity and specificity, the hope that all 3 independent reviewers would have very narrow confidence intervals to exceed the threshold set by the FDA. And then the FDA also wanted a cohort of T1A or also tumors less than 2 centimeters as additional endpoints. So this was a large pivotal study. There were about 32 sites. There was major centers, great investigators like Peter Mulders in the Netherlands, Viraj Masters, everyone knows in Emory, Alan Pantuck, a lot of big names in the kidney cancer field. And then basically what was looked at here is that there are about 300 patients. Most of these were clear cell as expected, but a good distribution of T1A, T1B, renal tumors, and there's a large number of patients. The imaging is beautiful. This is not like a questionable SUV of 4, like comparing it to the liver and say, is it positive? These things, when they light up very, very bright. The SUV is ranging from 11 to 86, and there's very low background here. Again, CA9 is expressed in the biliary epithelium and maybe some gastric epithelium, but it is very little kind of noise. When it's positive, even I can tell it's positive. And then the analysis was done, and the sensitivity and specificity were outstanding, similar to the I-124 trial, but because the larger cohort, the very clean agent, the confidence intervals were very, very narrow, and the lower bounds, which is what the FDA really cared about, was over that 70% threshold. So the positive predictive value was 93%, and I would say that some of the false positives were actually, high-grade papillary lesions, which are potentially also relevant. So maybe you may have some false positives, but those are relevant kidney tumors, which are more aggressive papillary ones. Now, again, there's very few AEs. Most of these AEs were mild. They were related to nephrectomy, and there were no expected safety signals. So this is obviously going to the FDA. There's an expanded access program. Everyone is excited about this, hopefully moving forward, but the FDA will do what the FDA does. Now, what about for metastatic disease? Everyone cares about, well, this is just a beginning. Can we use it in advanced setting? Well, there is a study from the Netherlands, again, Peter Mulders and his team, multiple patients who were going to be candidates for maybe for active surveillance of their metastatic disease. You know, Brian has a great paper, Dan George, a lot of people on active surveillance of metastatic disease. Well, maybe if we understand the burden of disease, we can maybe decide, should we treat them or watch them? So these are patients prior to systemic therapy. Everyone got a PET CT with FDG. Everyone got a CA9 PET CT and got a CT. And in this study, they diagnosed 449 lesions that were confirmed by multiple radiologists. And in terms of lesion detection, looking at a combination of the zirconium girentuximab with the CT, there was the most lesions found compared to a conventional FDG or CT alone. What is also interesting is that this is not, borderline SUV of 4 or 5, looking at maybe the lymph node or lung. The SUV values, it's a different scale. They're well above, baseline. So we're looking at maybe an adrenal lesion, which SUV is 250, is clearly going to be positive versus, one that's 5.9 and you're trying to compare it. So this is going to be a clear, easy thing to read for our nuclear medicine radiologist. We do have a trial which is going to be hopefully changing how we stage patients. It'll be 91 patients, just has got an IND, and we're moving through our approvals. Patients, we're lucky that we have a dual scanner which does contrast-enhanced CT and a PET CT together with very high resolution. Every patient after surgery obviously gets restaged. There's a discussion, should they get adjuvant therapy? Should they get systemic? Should they be observed? So these patients are going to get a questionnaire, seeing how it changes management, and we're going to be looking at a couple interesting primary, secondary endpoints. If any of your patients wants to take a vacation to LA, they can come get this imaging study, go back home with a UCLA hat. Summary, there's unmet need. We need to do better. FDG and PSMA have limitations. TLX 250 is safe, accurate for primary tumors. We're excited about it in the metastatic setting. And I think we're on the cusp of a revolution, not just for imaging, but also treatment. Thank you.
Thank you, Brian. Very exciting. Next, I would like to welcome Alan Tan from Rush University to discuss circulating tumor DNA utility in 2023 in RCC.
Morning. So we're going to be talking about some of the current evidence with ctDNA in kidney cancer in the adjuvant setting and also in the metastatic setting. Also trying to understand how we might incorporate the use of ctDNA in clinical trials. So cell-free DNA is a circulating free DNA that's usually spontaneous release of DNA in healthy cells. But within this fraction, there is, in cancer patients, there is circulating tumor DNA, which is fragments of active cancer cells undergoing apoptosis and necrotic necrosis. And so the challenge with ctDNA, especially in kidney cancer, is that it's a low-shedding cancer. In the patients that have metastatic disease across tumor types, we usually are able to detect patients' mutations with just liquid biopsies. But the challenge is when patients have early-stage disease, such as in the adjuvant setting, like in Keynote 564, that these patients might not have as sensitive an opportunity to detect the disease. So today, we're going to be talking about different applications of ctDNA throughout the disease course, but I want to focus today on the detection of MRD, or molecular residual disease, and also longitudinal monitoring of responses. So I mentioned that kidney cancer overall in general is a low-shedding cancer. We're looking into other technologies that are non-tumor informed. Lots of the examples I'll be using today are tumor informed, which do require tissue and whole exome sequencing to perform. But DNA methylation assays are being looked at as well. And Minetta Liu and colleagues did publish at the Annals of Oncology methylation assays across different tumor types. As you can see here, in cancers like colorectal cancer and esophageal cancer, there's some pretty good sensitivity even in stage 2. But as you can see in kidney cancer on the bottom left, it really misses the mark. Only in stage 4 disease, there's high sensitivity and specificity. What about, so Brian did a nice talk about PSMA or CA9 PET in kidney cancer, which may be a useful thing to diagnose kidney masses. Well, what about urinary tract DNA in patients with large renal masses? This is a patient of mine. He's 61 years old, presented with hematuria and a large left renal mass and an infrahepatic IVC thrombus. So this patient had urinary testing to complement his lung biopsy. His lung biopsies were actually negative. Sometimes we have challenges with CT-guided lung biopsies where we miss the tumor. And so about 2 weeks later, his urinary ctDNA came back with a VHL mutation and a SETD2 mutation, which are pretty classic for clear cell kidney cancer. So he was actually able to start systemic therapy without confirmed diagnosis of tissue biopsy, with the caveat that maybe he would have a delayed nephrectomy and we'd have a whole specimen to review later on. So what about MRD in adjuvant setting in kidney cancer? So we know KEYNOTE-564 was recently positive for overall survival, and this should be offered to our patients nowadays. But we're probably over-treating a significant amount of patients because some of these patients are cured with surgery. And so a month ago at ESMO, Smigelski and colleagues did a real-world multi-institutional cohort study of 61 patients in the adjuvant setting of kidney cancer, and they selected the MRD window at 13 weeks after surgery. As you can see here, 7 of the patients had positive ctDNA, but no evidence of disease on imaging. And here in the blue, you see these patients recurred and positive ctDNA was associated with poor recurrence-free survival probability, whereas the patients that were ctDNA negative, overall in the non-adjuvant cohort, they had a high negative predictive value of 97%. But I will say that there was also some concern because 5 of the patients in the adjuvant cohort, which is probably, these investigators are selecting the highest risk patients for adjuvant therapy. 5 of those patients were MRD negative at diagnosis, and they actually did have recurrence on scans without positive ctDNA. Eventually, 2 of those 5 patients did eventually convert to positive ctDNA, but this tells me that this is probably not ready for prime time in the real world setting to select patients for this adjuvant therapy. So Dr. Arnaud Basu and I collaborated together on this poster for GeoASCO, and we looked at 45 patients with metastatic RCC. So these patients have varying degrees of sites of metastases and tumor burden. So as you can see here in the middle, the swimmer's plot, all of those black dots are ctDNA positive patients. So 71% of patients actually had ctDNA positivity using a tumor-informed assay called Signatera. So what we also found is that a similar PFS type Kaplan-Meier curve was seen in ctDNA positive patients, similar to the adjuvant study. If you're ctDNA positive, you did worse, and if you're ctDNA negative, you actually did significantly better. But another interesting finding that we saw was that non-clear cell patients actually shed a significant amount of ctDNA compared to the clear cell counterparts. And this is some examples of a few of my patients with non-clear cell RCC with varying degrees of metastasis. As you can see on the side here, this is mean tumor molecules per ml of plasma. Some of these are in the hundreds, even thousands. This is a translocation patient up here with liver and bone metastasis shedding really high DNA and obviously progressing towards the end. But now you have a lower volume mediastinal adenopathy patient that also sheds up to 200, but also clears while being on nivo and cabo. And then we also have a FH deficient patient that has bone metastases and low volume liver disease showing recent progression on bevacizumab and erlotinib. So let's illustrate a case of how we can either intensify or de-escalate treatment based on ctDNA kinetics. So this is a patient of mine that's 77 years old. She had a history of oncocytoma in 2011, and then in 2022, she presents with progressive fatigue, weight loss, and this was all thought to be maybe related to some kind of thyroid dysfunction from her multinodular goiter. So she goes and has a thyroidectomy, and she was found to have clear cell RCC with metastasis to the thyroid. And usually when we see, these types of metastases, we think this is associated with an indolent process. But in this case, not all, kidney cancers play by the same rules. And she did have hypercalcemia. As you can see, the calcium levels throughout the last year, all over in the bottom, a lot of high levels there. But this was all kind of dismissed as some kind of hyperparathyroidism. So she was started on Ipi/Nivo for 1 cycle. And 3 weeks later, she is highly symptomatic, kind of deteriorating. And we know from Checkmate 214 that 20% of patients have primary progressive as their first response. And so I think, eyeballing this patient, she was going to probably be at high risk of dying of her cancer if she didn't have TKI next. So made the decision to start her on Nivo/Cabo. And pretty much immediately we see that her calcium normalizes a few weeks later. And then she sends me a MyChart message. Since we're, this conference, we're sharing a lot of patient stories. She says, I just want to cry because I'm so happy. I'm feeling so good. I'm stronger and I'm walking very cautiously without the cane. I'm not as tired. My breathing is better. And I was able to go out for dinner. I haven't felt this good in a year. So she's obviously responding to Nivo/Cabo, and this, it's kind of concordant with what we see from Checkmate 9ER. The improvement in quality of life actually happens quite quickly. So she goes and has a deep molecular response and also a radiographic complete response. A year later, she's left with a kidney mass that ends up being resected and being completely negative for any residual tumor. So she has a complete pathologic response, and she has a CR on scans and molecular response. She is now off therapy and very grateful, and so is her family. So we have a lot of options in frontline settings now. Recently, we had updates of Keynote 426. This is the first IO-TKI FDA approved. And while initially the overall survival benefit looked very impressive, we're now seeing the curves are starting to meet with the IO-TKI combinations with Keynote 426 and with the CLEAR study. And we're not seeing that tail of curve, at least just not yet, as we are with Ipi/Nivo from Checkmate 214. And so we argue that if we're not curing these patients, can we at least improve their quality of life while on IO-TKI? And the START study actually proved that patients that had breaks up to 3 months at a time actually could do quite well by adopting the strategy of intermittent IO-TKI. Oh, sorry, TKI only. But could we achieve the same thing with IO-TKI? So a month ago at ESMO, Dr. Iacovelli presented a nice smaller study called the TIDE-A study. And he looked at 75 patients with clear cell RCC and measurable disease. I will mention that they did exclude really high-risk patients, so very few patients had really poor risk disease, and 40% of patients had good risk disease. And they excluded liver metastases and primary tumors that were intact or bulky symptomatic disease. And what they tried to show is, could you de-escalate an IO-TKI regimen such as axitinib and avelumab, and still not harm these patients? And so their aim was to show that more than 48% of patients who were able to discontinue axitinib at week 36, could they still be progression-free 8 weeks later? And they actually surpassed that by, they had more than 72% of patients discontinue it safely and become progression-free at 8 weeks later. Furthermore, median progression-free survival was about 2 years, and the landmark PFS was 70%, landmark OS was 94% at 18 months. But importantly here, we're talking about quality of life improvements. Once these patients stop the TKI, their grade 1 and grade 2, grade 3 side effects have almost completely dissipated. So the FDA has now released guidance for us investigators and industry to help incorporate ctDNA into our clinical trials, whether it's to intensify or de-escalate treatment. And a week ago, I presented a concept at the Alliance for Clinical Trials in Oncology, looking at patients that are started on a TKI-based regimen. And so we would include clear cell and non-clear cell kidney cancer that had measurable disease, but they also have to have a biopsy for whole exome sequencing and a tumor-informed ctDNA assay. And these patients would get randomized 2-to-1 to get the de-escalation treatment after 6 months of IO-TKI. And the standard of care patients would continue standard of care IO-TKI, and they were allowed to get breaks per toxicity. But if you had initial positive ctDNA and you were able to clear that ctDNA, you're able to stop your TKI and continue monitoring with the molecular test every 6 weeks. I think this will give patients more comfort that they're still being watched carefully, and upon molecular recurrence, they're able to restart their TKI treatment. You may even argue that they could stop the immunotherapy as well. So we may give an option to stop the immunotherapy at a year if they had a good response. If they actually were ctDNA negative at diagnosis, then I argue that these patients have a good prognosis to begin with, and maybe they can be followed with just imaging and have probably the best PFS. So this is going to be a non-inferiority study. We're trying to really prove that this will have at least the similar outcomes as the standard of care patients. But importantly, we're going to be looking at health-related quality of life as well. So IMDC, I think, if you ask many kidney cancer experts, may miss the mark in the current age. So should we be incorporating some more novel techniques into the IMDC? Well, probably not just yet, but maybe the Mozart-Rini cluster should be incorporated, and maybe ctDNA positivity may add another point to the IMDC risk score. So take-home messages for Monday. Really, ctDNA in RCC is a low shedder and likely inadequate for adjuvant decision-making in our Keynote 564 population. But I think real-world use of longitudinal ctDNA in the metastatic can be highly informative if we want to intensify treatment or de-escalate treatments. We showed in the patients that are in Ipi-Nivo, we don't want to lose these patients at the expense of trying to get that durable response. Some of these patients end up dying within the first 3 months of therapy. So we might be able to monitor these patients much more closely. And we do need to have more prospective clinical trials to validate ctDNA as an informative biomarker. And I want to also thank the Kidney Cancer Association for allowing investigators like us to continue doing better for our patients so these patients can live longer and better lives. Thank you.
Great talk, thank you, Alan. I'm sure all of us would love to have a reliable way to take our patients off TKIs, right, with all the toxicity associated with them. So moving on, it's my pleasure to welcome Dr. Ivan Pedrosa from UT Southwestern to discuss the role of AI for localized disease. Ivan?
Thank you very much, and thank you for the invitation to the committee. This is a long title. So the goals for me are to really recognize, as you heard before, what are the unmet clinical needs from the point of view of radiologic assessment of renal masses, localized disease, to review different approaches for advanced image analysis in these masses, and also understand some of the challenges for broad applicability of AI in clinical practice. So you probably have seen this graph before. The incidence of kidney cancer has increased dramatically over the last few decades, mostly because of the use of cross-sectional imaging. We're detecting these tumors incidentally. And although we're treating them when they're small renal masses, the mortality hasn't really changed that much. So we're probably over-treating kidney cancer for the most part. So we need to really understand what's indolent and what's aggressive, what needs to be treated, what does not need to be treated. We also, you heard before, in the last decade or so, more than 30% of the partial nephrectomy is done in the United States, and actually data also worldwide seems to indicate that these are benign tumors, so these patients may not benefit from those surgical procedures. So we need to understand also what's benign and what's malignant before we decide on treatment. Now, different approaches to advanced imaging analysis. You've heard the word radiomics several times in the last couple of days. Radiomics is nothing else than converting images into numbers. So we're converting the pixel values into a matrix, and then we're actually doing sophisticated statistical analysis to try to remove data from those images and make decisions based on that. And there's enormous now amount of data out there on radiomics to try to distinguish benign from malignant, fat-poor AML from renal cell carcinoma, oncocytoma versus renal cell carcinoma. Those are all papers that are published in the literature. Now, I will argue that you need to include all kinds of tumors, so you really need to want to use this in clinical practice, right? We don't distinguish oncocytoma from renal cell carcinoma. We have an indeterminate renal mass. We need to understand what that is. A bigger problem is that when you compare the same images with 6 different platforms at different sites, you get completely different answers. And it's not the radiologist performing the region of interest analysis around the tumor, because the inter and intra-reader agreement was excellent. It's actually the software output that is completely different. Even for first-order statistics, such as kurtosis, I'm giving you an example here on the right, only 25% of the pairs that we compare actually provide a robust, a strong correlation of that value. And if you get to second-order statistics, what we call texture features, heraldic features, etc., then it looks even worse. Only 3 show a strong correlation. So we need to really standardize the way we do this analysis. And this is just talking about the same image exposed to 6 different packages. We haven't even started talking about standardization of the image acquisition, right? The timing of the contrast, the slice thickness, the metrics. So fortunately, we have another approach, and again, I'm going to be very open. I'm skeptical about radiomics for those reasons that I suppose. I think standardizing the way we acquire images across different sites is virtually impossible. But artificial intelligence can actually read through that to some extent. And that's because these convolutional neural networks actually think more like humans. They replicate what we do with some inputs. We can use some weights and biases and thresholds, and then provide an output and compare that to the reference standard. And of course, with deep learning being the most commonly used approach now, where we have multiple layers in these classifiers. So let me talk a couple of things on data that's out there already, starting with cystic masses and distinguish benign from malignant cystic masses. Why do we care? Well, when we talk about cystic masses, and I'm talking from the radiological point of view, not from the pathological point of view, these are masses that have a lot of fluid signal. As you can see in this MRI, the fluid is bright, and the solid component is dark. So when we actually classify these masses based on the amount of solid versus cystic tumor, it's actually a very good prognostic biomarker. If the mass is more than 75% cystic, the outcome is absolutely outstanding. The likelihood of recurrence after nephrectomy is negligible. And this is why the Bosnia classification that we have been using in the last 40 years, and the urologists used to decide to treat or not to treat, has been modified in the last few years to try to be a little more objective in the amount of solid component that we see. So we provide now criteria in terms of the number of septations, the thickness of the septations in the wall, as well as the presence of nodules and obtuse thickening. So think about it, that's actually a very good problem for a machine learning algorithm, and in fact, it does pretty well. And this is data from a group that look at cystic renal masses, and you can see that the distinction between benign and malignant approaches 0.9 or a little higher, actually than 0.9 in that distinction with machine learning classifiers. Now we need to do a little better than single institution analysis, and that's why we have these international challenges that are proposed where well-curated data sets are put out there for investigators to develop their own algorithms, and this is one of them in doing segmentation of the kidney and kidney tumors, which is actually the first step if we want to use machine learning to classify renal masses. And you can see that the winning algorithm does really, really well. The DICE coefficient actually measures how close is the outline of the machine learning algorithm compared to a human doing the outline of the kidney or the renal mass, and one will be perfect. So approaches 0.97 for a kidney, a little lower for the tumor itself, particularly when they're small, about 0.8. Now, one thing is also to be considered, and I applaud these investigators for actually providing the source of the data that they use, mostly coming from the same region in the United States. Now, why this is important? Let me show you another paper published for my colleagues at UT Southwestern. This was an AI algorithm trying to predict COVID pneumonia. COVID pneumonia presents with these ground glass opacities on chest CT. So they developed an AI algorithm for this detection with our data, and it looks really, really good. It actually performs great. And then they compare this data with other algorithms that have been published in the literature, very large cohorts in the tens of hundreds of thousands of patients, and those all reported excellent accuracy, 0.6, 0.9, and area under the curve. You can see the values there when they tested with their own data set where they were trained. Now, if you combine all those data sets and you try to test those algorithms, they perform a little better. But if you actually compare any of those algorithms to data from another site, then they fail completely with an area under the curve that is about 0.5, similar to chance. So we need diverse cohorts of patients so that we can actually test these algorithms and see how they perform. How about solid masses, starting with benign versus malignant disease? Well, this is a study that looked at combining MRI data, including T2-weighted images and T1 post-contrast images, with some clinical variables, such as age, sex, and tumor size. And the model accuracy, I mean, there's some signal there, 0.7, distinguishing benign from malignant renal masses, but I don't think that will be enough to make clinical decisions. How about tumor grade? As you know, biopsy is not perfect. There's sampling error. The biopsy to nephrectomy grade concordance is not great, 0.6 to 0.8. And of course, imaging can analyze the entire mass, so potentially will be a way to address the heterogeneity. And again, data here comparing low versus high-grade tumors with CT and MRI. The CT may be a little more robust than MRI, using convolutional neural networks and with pretty good results. Here's in the curve close to 0.9. Again, single-center data. Some are interested in looking more at mutations, for example, PBR1 mutation detection from 0.92, or predicting CD8 T-cell infiltration, also 0.9. PDL1, not as good in terms of really predicting the expression. Now, also important is that when we look at this paper, it's not always clear how the data curation is done for training and validation. And I'm going to post a big problem in this type of analysis is data leakage. And by that I mean, if you take 2 slices from the same scan for training, and then you take a third slice for validation, technically you are actually separating the data from training and validation. But of course, that slice that you use for validation is more likely to be similar to the other 2 slices than any other slice from other patient. So your algorithm is going to perform better than it should just because of this data leakage. The data needs to be separated at the patient level, not at the study or CT level. Now, in the last minute, I want to show you another approach that we're using, and this is really focusing on creating a pipeline for AI in renal masses. And this is a typical clinical protocol in most institutions, a multiparametric MRI for renal masses, looking at T2, T1, in-phase, out-of-phase, diffusion, and then post-contrast images. Now, the challenges with annotating these images by humans is that extremely time-consuming because you're going to have to segment every single image that shows the tumor in this study. And of course, there's respiratory motion, so the images move up and down. There's different field of views, different planes. So again, annotating all these images is extremely time-consuming. So we've been using an approach, it's called deep learning with a style transfer, which is the algorithm that's used to create zebras from a horse image or a summer image from a winter image. And the concept here is that we're going to annotate only one set of images, the T2-weighted images. And we create synthetic MRI images from those T2-weighted images that simulate the post-contrast images. Now, because those synthetic post-contrast images are perfectly aligned, we can actually use the masks that we created for T2 and train a masked CNN to segment the kidney on those synthetic images. And then we can use the original images that are not well aligned and use the same CNN to do kidney segmentation. And in fact, it does really, really well. And you can see here in yellow is the human annotation on the T2-weighted images. If we try to copy and paste those directly into the real post-contrast images, it doesn't work. Again, the patient is breathing differently, there's different field of view, et cetera, et cetera. But our CNN actually does really, really well in segmenting the kidneys on the real images, as you can see in blue here, and actually does better than the inter-observer variability between two humans doing image segmentation. So hopefully I didn't sound too negative. I think there's a lot of promising in AI and the characterization of localized disease, but there's still long ways to go to be able to use these in clinical practice. We need multi-center validation with diverse patient populations. I can't emphasize that enough. This is crucial to enable that clinical implementation that we're all looking for. Thank you very much.
Thank you, Ivan. Next, we have 7 minutes for questions and comments.
Thank you. I have a question for Brian about the CA9 PET. So it should be very specific for clear cell. So a couple of things. First of all, have you thought about saying whether it's a predictor of early predictor of response to belzutifan? And then also, so what would happen if you're imaging a small primary renal mass and it's negative? Then how does it help you really? It helps you if it's positive, of course, but how do you think about the clinical applications of a negative?
So in terms of like response to therapy, that hasn't been done, but obviously if you block HIF2 and you change your downstream expression of CA9, maybe it'll become cold. That'll be maybe a good surrogate for activity. But if it shrinks, it's also a good surrogate of activity. In terms of the scans which are negative, there's other modalities like biopsy which could be implemented. You could do, again, we have plenty of great data from Ivan and others looking at, we're really good at predicting papillary renal tumors. I think our radiologists are 85 to 90% accurate when they say papillary. But Sestamibi is there too to maybe pick out some. So I think the algorithms might change in terms of how we approach it in a stepwise fashion. It's not going to be all or none.
Right. Thanks.
Dan?
Hey, so thanks so much. Great session. Brian, I have a question about the PET scan. So, we commonly see those patients up front with large tumors where we struggle about doing nephrectomy if they have a lung nodule, like an 8-millimeter lung nodule. We struggle with the question nephrectomy up front versus systemic therapy if the lung nodule were to grow versus, SPRT to the lung plus nephrectomy. Do you think the PET imaging would be sensitive enough to give information on an 8-millimeter lung nodule as an example?
Yeah, in that study, the impact study, 4 sites in Netherlands, they were able to detect metastatic disease. We're using it more, we're trying to do it post-op for staging, discussion of adjuvant versus more aggressive or less aggressive therapy. But if you look at that study, there are some small lesions that were detected. We actually had a couple Bosniak 4 renal masses with, kind of a small nodule, and those were positive on the scan. So, I think, probably not a 1 millimeter or 1 cell, but there's going to be some small lesions, which I think it's going to be useful for those questionable tiny lung nodules where you're not sure what to do.
Do you think the FDA will evaluate the approval for that purpose as well, or not?
I don't think so, because the trial really was mostly abdominal imaging. Yeah. There were some sites that did full body, and they did detect sites like adrenal, lung, but I think less than 20% of patients had whole body imaging.
Okay, thank you.
Laurence?
Great session, congratulations. So my 3 questions are about ctDNA. The first one is, do you think in one of the cases you share, you could have an initial surge in the ctDNA release in a great responding patient? Because I'm a bit puzzled by the fact that your patient was actually YPT0, meaning incomplete response. Could be maybe related to the fact that he had early exposure to nivolumab, ipilimumab. Have you seen that in your longitudinal follow-up?
Thanks, Laurence. That's a great question. So as far as the flare, I think, in that patient, she may have eventually been a responder to IO-IO, but after one cycle, as you know, that's probably not enough. But did she get a pathologic complete response because she got that one dose of IPI? I'm a little agreeing that that might be the case, even though it's just one dose of IPI. I usually don't see patients that have durable CRs on an IOTK regimen. As far as the flare, I think the only situation where I see flares is when you have incorporated radiation into your ctDNA time point. And that I would highly discourage. Even though the half-life of cell-free DNA is less than 2 hours, if it's in that peri-radiation setting, you're going to have a significant flare.
The second thing is, do you think we could use it to decide upon delayed cytoreductive nephrectomy? Like in your case, because there was no more ctDNA, was it relevant to perform the delayed CN?
Yeah, I'm hoping that if you do have a high burden of ctDNA tumor fraction in the beginning, and you have a sharp decline of clearance, I think ctDNA clearance is a really powerful endpoint that we should be looking at in all solid tumor types. But in kidney cancer, durable clearance of ctDNA is probably our best biomarker, but I think we should probably correlate this with some of our clinical trials. So Olga Val-Champagne has a SWOG 1931 study looking at patients with metastatic disease, and they get delayed cytoreductive nephrectomy. And so far in my real-world experience is that, yes, that kinetics is really showing us that we may have better outcomes, and maybe we could defer cytoreductive nephrectomy in these patients that have systemic complete response and perhaps shrinkage of that primary tumor, but maybe in correlation with girentuximab PET too. If that PET is completely negative and also ctDNA is clear, maybe we could leave those kidneys alone.
And so maybe last question, it's about the techniques you've been using. I understand it's like regular ctDNA assessment. What is your take on new modalities such as methylation marks?
Right, so I showed that one study by Mignetta Liu and colleagues, and this is a non-tumor-informed assay, so there was some promise that maybe this might be better for kidney cancer, but as you saw, there's in stage 1, 2, and 3, it really missed the mark. So I'm not very optimistic about that also being a great biomarker. I am more optimistic about other serologic markers, such as something called the oncoRNA. We're looking at other proteins that are quite abundant, and you could just use 1 ml of blood and probably get higher sensitivity and correlation of actual residual disease. But more work to come on that.
Thank you.
Thanks.
All right, great. I think we are on time now. I would like to thank the panelists and all the audience for listening. Thank you.
Thank you.